Hello, everyone. How are you guys doing? Yes, it's me again, Decency Onyekachi, the vendor of good news, coming to you today live from Virginia, United States of America. And today we have a very interesting personality in our midst. Okay, her name is Decency Onyechi, happened to be my beloved wife. Okay, so but aside from that, we're not going to be emotional today. We're going to be very, very straightforward. We're going to be straightforward and on point. Please, as we are going through the interview, I would like you to save your questions. If you have any question about relocating to the United States, any question about all the things that you might need, things that should help you in your relocation process, this is a go-to person. This is a one-stop shop for you to get that from. Okay, so I believe she'll be able to help you guys with all the questions that you might have today. Choma from Nigeria, thank you, and you're welcome. All right, so she is, I mean, she has a lot of spheres of leadership that she has been through here in the United States. She's been a nurse manager, she's been a manager, a consultant, then a manager and almost a director at a company here in the United States. And she has also been that's nurse manager. Do I have to mention the hospitals that you've been a nurse manager in?
No.
Specialty sake, okay?
No.
So I will save you guys the stress of all those names, but she's been a nurse manager, she's been almost a director at a company in the United States, and she's been in different spheres of leadership. Even in the DNA, she's also wearing the cap of the director of finances. Okay, so she's been a great support to the great growth of DNA as a company and DSS as a company as well. All right, so she's a registered nurse. She has a master's degree. She's pursuing a doctorate degree as well as it stands now. Okay, so
guys, good to be in your midst tonight. Wherever you are watching us from, we appreciate you being here today. Thank you so much for joining us. And be willing and open-minded to also learn. Keep your questions. At the end of the program, you can ask any questions that you need to ask, and I will be willing to answer to the best of my knowledge. Thank you all once again, and welcome.
All right, so guys, one thing that is, thank you for that welcome that you gave to us. And one thing that is common with everybody here is that we are all nurses from Africa, and we, in different times, we've either immigrated to different country or we are planning to migrate. So I know you have gone through this process, and I would like to know what inspired you, to really migrate from Nigeria to the United States of America.
Thank you, Mr. Decency, for that question. So my decision was inspired by the desire for professional growth. I am Oliver Twist. I want to know more. Yeah, I want to know more. And also I wanted to gain knowledge about advanced technologies. Let me say I've worked in best hospitals in Abuja. I wouldn't be wrong if I say that. I've worked in several hospitals that are really, really good, so I've seen it all. I needed to know more. So that's one of the things inspired me to pursue this career. We have seen, like, I'm an OR nurse, so I'll be making reference to the operating room because that's where I worked, so I've seen many surgeries we've done. I've seen the laparoscopic side of it, but I heard about a robotic surgery. I've never seen that done anywhere. As at the time I was in Nigeria, if they're doing it now, it's a plus. But as at the time I was still in Nigeria, I've not seen any hospital that does robotic surgery. So, and I've read and I know that they do it in America. I'm like, okay, this is a good place for me to gain this knowledge. It's one of the things that really inspired me. Also, expanding my knowledge, expanding my skills, safer practice. In America, I will be honest with you, you have a safer working condition and working environment compared to some or most African countries. So I needed to experience that. I've had friends that are in America that have told me, hey, You can't even compare, oh, America is this, nurses have autonomy, nurses can do this even without the doctor telling them to do it. You can do it and then call the doctor to get an order. You know, a patient can be in crisis right now. Of course, you can't start looking for the doctor. Every single time matters a lot. So you don't even waste time. So do the actions. They have policies, they have procedures, they have policies and procedures that guide each hospital. So this is one thing you're to go that you have to be with every time. I mean, it's in the computer, log in and read about the policies and procedures. Know your limits, know what you can do. That is one of what is going to help you. So in America, they don't waste time. You know, I've heard about all those things and I'm like, okay, I would really like to experience this. And yes, I have experienced it and I'm really, really happy that I have experienced it and I did, and I'm still experiencing it, you know. For instance, like I was using a patient that's in crisis, just check, oh, this patient is in crisis. Do I have to wait for this doctor? No, go ahead and do what you have to do at that time. When the patient is stable enough, go ahead and call the doctor. Hey, this patient was in so crisis and I did this and I did this. The doctor will say, okay, write down the order for me. The order you would have called him long time ago to get. You know, you don't know where he was at that time. Probably he was, you know, somewhere with family. He wasn't even with his phone and patient is dying and you're waiting for a doctor to get an order for something you can do. You know, so do it. And whenever the doctor comes in or even at home, he can log in and approve that order. So those are the things that I really looked forward to. And they are part of the things that inspired me to pursue career as a nurse in America. Thank you very much, Mr. Decency.
I want you to give us a rundown from clock in to clock out. What is your daily schedule like? I don't know if there's any operating room nurse right here that is listening to us. Do we have any person who works in the OR in the audience? Do you have anybody that works in the OR? If you work in the OR, say I work in the OR in the audience, or if you don't, that's fine. But she's going to give us a little breakdown of what a day-to-day activities of her day is. Like when she gets to work, you clock in, or what are all the activities that take place until you clock out? Can you run that for us? Run through, take your time. We have all the time. Don't try to rush. Just take your time and go through all of the things that you do in your day-to-day activities in the US. Because that's the clinical adaptation we're talking about. We're going to come back to, you know, asking more personal questions, but I want to be able to let the audience understand you, then we can move from there. Is my question clear enough?
Yes, sir. Thank you very much. I mean, operating room is just my home. I mean, right from nursing school, most of my posting was in the OR. I grew passion. I developed passion. Well, if you don't have a passion for anything, you won't go far in that thing. Let me just put it that way. I was so passionate about operating room that even as a student, then they can leave OR for me to manage. Maybe they have somewhere they are going, they are short-staffed, they will call me, hey, Oyinye, come and take over this OR for us. It happened. And I'm happy that I did. I remember I'm just giving you a background why I'm so passionate about OR. I remember one of the nurses in the OR where I trained had an interview somewhere in Abuja. He couldn't get anybody to cover him. They had to pull me from the school. I'm saying this here. I know, I know someone is here that is like, oh, you were doing this. So yeah, they had to pull me, take permission, and they pull me, and I'll come and cover the OR for them. So when I came to America, oh yes, I've received some recognitions as well as an OR nurse. OR is very sweet. It's a very interesting area. It's like a family, you know, coming together to work. So my daily activities in the OR, once I come in, clocking is not like in Nigeria, in most African countries, do we clock in? No. Do we have a place to
you
write
don't clock
our
in
name?
here, you don't get your money, you don't get paid. So
Exactly.
clock in, you get your money.
If you don't clock in, it's as good as you didn't come to work. You know, unless you have to go back to your manager and tell her, hey, I missed my clocking. And if you can do it on your own from the computer, that requires them going to verify. So instead of doing all those things, just save yourself the stress. Go ahead and clock in. And this is my daily routine every day in the OR. Once I clock in, the next thing is I go in, pick my scrub. We have a scrub dispenser. It's not like in most African countries, in quotes, where they keep scrub. In fact, most times you're even looking for scrub to wear, you know, but this one, you have scrubs in the machine. We call it the scrub dispensing machine. Go there, pick your scrub, use your batch. Everybody has like 2 scrubs. Even if you have one, you are working and one gets stained, maybe with blood, and you needed to change. Go ahead and drop it back into the machine, receiving machine, then go and get the second scrub, you know. So use your batch, get your scrub, go and change. Once I change, the next thing I'm going straight to the board to see the room that I'm assigned to. You know, once I see my room, I see my team, who is my surgical tech, who is my CRNA, that's the nurse anesthetist, like we call them in most African countries. Then who is my surgical assistant. You know, back home where I come from, nurses scrub. But here in America, we have people that we call scrub technicians. They are the ones that, even though some hospitals still use nurses to scrub for cases, you know, but they are just known for that. They are the ones that scrub, you know. So once I know my team, the next thing is to go into my room, start getting things ready. Of course, the people that did night must have set up the room, not really setting it up completely. The things you need for surgery for that day, they will bring it into the room for you. Maybe for your first case, it's in the room. All you need to do is to come in, write on the board the names of those you are working with, the surgeon, or you have to write on the board, because during timeouts, you have to read what is on the board. The surgeon doesn't need to come and start asking you, hey, who is my ST? Oh, no, Stephanie, who is my SA? Once they come in and they look at that board, they already know, oh, Steph, I'm working with you today. Oh, it's going to be a great day. Oh, Tim, I'm working with you today. Oh, it's going to be a great day. And that's it. Write the patient's information, write the date of birth, write the procedure we are doing on the board, write the side. If it's on the right side, if it's on the left side of the body, you have to write it. Is the patient allergic to anything? You have to write it. Is the patient high risk for anything at all that you know the team needs to know of about that patient? Write it on the board, okay? Then this is after I have logged in into my Epic and checked the patient, know the patient, make sure the lab values are okay. Of course, you have to. If there is any lab value that is not okay, you have to alert the team. Maybe the hemoglobin level is very low, or you have to let them know. If it's something they need blood, they need to get a blood into the room before the surgery, they will tell you. If it's something that they need blood to be in the hemobank, we have something we call the hemobank. Instead of going straight to the lab, sending people, oh, go and get blood for me, there's a machine we call hemobank. It has blood. The patient has been cross-matched, grouped, and all that. You put the blood in the hemobank. Once you need it, instead of leaving it in the room, just go straight. It's still within that OR environment, okay? Go straight, scan the patient bracelet that contains the patient information. It has a barcode. Once you scan it, it shows you everything. Then pull the blood from there. So these are the things, the preliminary things you do to get ready for the day. And when that is all done, you've checked everything is ordered, start opening your case. And you have to make sure all your team are in the room. You don't want to start a case or close to getting your patient into the room. You find out that, oh, where is my surgical assistant? Those are the things that is going to delay the case. You don't want that. If you are in the room, of course, knife on skin, or patient should be in the room at least 7:30. If that case, if they usually tell you the times, if sometimes, if it's the days that we are doing meetings, like education, we usually start surgeries around 8:30, 8:45 a.m. But if it's a normal day, surgery starts at 7:30 a.m. At least the patient needs to be in the room at 7:30 a.m. Anything outside 7:30, the patient is late in the room. So you don't have a case starting at 7:30 and at maybe 7:15, you are going down to the pre-operative area to get the patient and you don't have your team in the room. You have to let the charge nurse know, hey, I don't have this team member in my room. If they have a replacement, they will send one immediately. Before you go down to get your patient in the OR, very important, make sure your instruments are sterile. If you open your instrument tray and it's stained with water or the paper lining has a hole in it, it is considered contaminated. You have to take it back to the CSSD so that they can give you another tray. Even your pack, as little as opening a lap gauze or even a gauze like we call it, if you notice that the pack is torn or has a hole, you have to discard it. So all these things has to be in place before you go to get the patient. If it's a surgery that requires implants, you must have that implant in the room. The implant has to be in the room. We don't want to start a case and it's time to open implants. Hey, I don't have this implant. You don't, any second you waste in the OR matters a lot. It's a fast-paced area to work, but it's also very nice. It's also rewarding. So when you get your patient when you go down to the pre-op, you see your patient. Hey, Mr. A, good morning. Of course, you introduce yourself to the patients. Check the consent. Is the consent signed for the surgery? If it's not signed, you cannot take that patient to the operating room. Oh, Americans are very good with suing people. I want you to have it at the back of your mind. Patient knows their rights. Do you understand? It's not like in America, patients are the decision makers when it comes to their own health. It's not like most African countries that their families take decisions for them. Maybe this person wants to go to surgery, it's the family that will decide. No, in America, the patient can decide for himself. So make sure that that consent is signed. Even if by mistake, you take a patient to the room without a consent and it's during timeout and it was discovered that this consent was not signed, you cannot go ahead with that surgery. You have to reverse that patient. Even if the patient is under anesthesia, you cannot. You must reverse that anesthesia and bring that patient out and reschedule that case. It is that they take it that serious. So as a nurse, this is your role. Make sure everything is in order. Make sure the surgeon signed the consent, has signed the consent, and the patient has signed. Make sure that is the procedure that you see when you logged into the computer that is on the consent form. Sometimes the patient will have something on the consent form and it's different from what you saw in the computer. You have to stop and ask questions. Those are the things that can warrant you to be late in the room, because of course you can't be rushing. Oh, my case is starting at 7:30. Let me rush so that, and then you come into the room and there is a problem. At that time, you become a failure. So if there's a discrepancy from what the patient, just last week, patient says, oh, the patient is supposed to do just a hernia surgery. Yes, and the patient was now saying, oh, they told me that I'm also doing an angiography. I'm like, no. Who is going to do that? This is general surgeon doing hernia surgery. Angio is going to be done by a vascular surgeon. So what's the relationship? I was confused. I said, no, and the CRNA looked at me. I said, what are we doing? The woman was insisting. The husband was insisting. Yes, that's what they sent to us. We even signed it. I said, okay, hold on. I called the doctor. I said, hey, please, you need to calm down and explain to this patient, because what we are doing is totally different from what she, assumed or seems to know. So the surgeon had to come down and say, oh, no, don't worry about that. That's the surgery for another time. When we are done with this hernia surgery, it's another surgery that you need to, get done. We're not doing all of them today. And patient was like, oh, okay, I didn't understand it that way. These are little details that you must clear before you bring that patient to the OR. Surgical marking site. If the surgery is going to be on the right hand, make sure the surgeon marks it. You don't want to bring a patient into the room and assume, oh, it's on the right, and it happens to be on the left arm. That's a big trouble. I got a recognition one time in one of the hospitals. I just started my first 1 week. I just started walking and I went to bring this patient. On getting to the pre-op, the consent says right arm, right leg, right lower extremity. That's how we do it. And then that's what the consent says. And then the surgeon marked the left lower extremity. I was confused. I said, I asked the patient, where are we working on? The patient said, we're working on the right side. I said, okay. I went to call the doctor. Some of them can be arrogant. I want you to know that. He did not believe me. He said, what do you mean? I've been here for years. There's no way I will make that kind of mistake. I said, can you please, even if you don't want to come and see this, send someone to come, send your SA, send your resident, let them come and take a look, because I know what I'm saying. I'm here with the patient. And then reluctantly, he sent a surgical assistant. On his way, he was saying, I don't know what you saw, but he can't make that mistake. And then when he got to the patient's bedside, indeed, he marked the wrong side. And he went to tell the surgeon, hey, guy, you marked the wrong side, He came back. Instead of him to say, I'm sorry, this, he just said, that's why we are team members. But that's, by the way, that's why we are team members. That means what I don't see, you see it. But when I was telling you what I saw, you never believed it. You never believed we could be team members at that time, So little details like that, you make sure that the site is marked. That's the hallmark of the surgery even. You can't bring in a patient without the sites being marked. We don't want to come into the OR and do surgery on the wrong side. You are going in for a lawsuit. That is it. And then when you come into the OR, I didn't do, so when you come to the pre-op, after seeing your consent, let me take us back a little bit. You go to the patient, you have to ask some questions. Even though you know this patient, but you still want this patient to tell you who he or she is. You check the bracelets, the armband, you read the name, confirm it with what you have on your, we are that thorough. Confirm it with what you have on your consent form. Mr. A, okay, I know a lot of people have asked you this same question over and over again, but it's just for safety reasons, okay? Do you mind confirming your name and date of birth for me? And the patient will just laugh because he or she knows 1,001 people have come in here and they have asked me, confirm your name and date of birth. We want to do it because we don't want to enter into trouble. We don't want you to come and sue us at the end. And they will tell us, oh, my name is Mr. A, my date of birth is so. Okay, in your own words, can you tell me the surgery we're doing for you today? And the patient will tell you, oh, I'm doing this, then you go ahead. Okay, if he's on the right side, did the surgeon mark it? Was he here to see you today? Oh, yes, he came. What about the anesthesiologist? Oh, have you seen him today? Did he explain everything about the anesthesia, the process, and all that? You say, oh, yes. If the patient at any point say, no, I'm not clear with this, you have to stop and go and get the anesthesiologist or the surgeon to come back and explain to them. You are an advocate at that time. Do you understand? So also, okay, did you eat anything today? Sometimes I don't even ask them, did you eat anything? I will just go straight. What did you have for breakfast today? I was able to catch a patient. If you ask me, oh, did you eat anything? Because I was told not to eat before surgery. It's easy for me to tell you, oh no, I did not eat anything, but I will just come straight. Hey, tell me, what did you have for breakfast today? And one was honest enough to tell me I just had a bacon and a little sandwich. And I'm like, oh, you did. And he realized what he has done. He even started laughing. I'm like, thank you for letting me know. And that surgery was canceled. And also after that, allergy. We don't want to bring in a patient that has latex allergy in the room and we are using a latex glove. That patient is going to react to it. We don't want to bring in a patient, for instance, that has allergy to sulfur medications, and you come into the room, you're giving that patient a medication that contains sulfur, maybe an antibiotics. We don't want to do that. The patient will start reacting to it. So know the patient's allergy as well. Know if the patient has metals anywhere, especially in the leg where you're going to put a bovie pad. Bovie pad is we use it to limit the bleeding is a cautery. We use it to limit bleeding. So you don't want to put a bovie pad on a metal. It can shock the patient. We don't want to do that, okay? So these are all the questions you ask this patient. Ask the patient who is going to be with you after the surgery. Is there a family member in the waiting room that we can reach if there is any emergency that we need to talk to someone? Maybe this is the consent you signed and there is a clause that we might be doing this, and we enter inside and, oh, we need to do this, and we have to have a family member to notify, oh, okay, now we want to go ahead and do this. We want to know who we can call. There should be a number that the patient can tell you, yes, you can go ahead and call so person. And when you're done, of course, yeah, they're saying bye, not bye forever to their loved ones. Do you want to give your wife, your child a hug or a high five or a kiss? And then you take the patient to the OR. It's so calming. It's so reassuring, And also they receive their relaxing medication for them to be calm. Some of them are usually not even some, most of them are very anxious. They are scared. They don't know what they are going into face. So you give them that relaxing medication, maybe Valium, give it through the IV, and they are relaxed. Then you bring them into the room. Yes, Mr. D, please.
Yeah, I just want to make sure that everybody is following us because everywhere is so quiet. So I want to make sure that everybody is following. So please kindly go to the comment section. If you're still following, kindly type following on the comment section so that we know that we still have everybody in the room. It looks so quiet. You've been the one talking, and I want to make sure that everybody is getting value for their time today. So kindly go to the comment section and type following for me. Thank you so much for all the people that have, and I also wanted to give you a chance to get a small breath so that you can continue. So thank God everybody is following us. You can go ahead, Ma. Go ahead.
Thank you very much. Okay, so now we are done in the pre-op. Pre-op is where they prepare the patient, right? The next thing is to bring the patient from the preoperative room, from the preoperative area to the intra-op area. Intra-op in perioperative means preoperative, intra-op, and post-op. That is just it. So pre-op is where you prepare the patient, all the labs, everything, make sure is in order. Intra-op is where the surgery is taking place. So once you come into the room, you have to reconfirm again, who is this patient? Hey, Mr. A, can you please one more time tell us your name? Each time you ask them that question, they will just start laughing. In fact, when you come to pre-op sometimes to ask them, hey, I know you've been asked this question many times, but I have a few more questions. One, just yesterday, one just said, I already know. My name is this, my date of birth is this. I did not eat anything. If that's what you want to know, I didn't eat anything. I just started laughing. So it can be that funny. So when they come into the room, like it's story. Okay, when they come into the room, you ask the same question before they start giving anesthesia to these patients. Confirm the surgery one more time, because at this time the patient is going to go to sleep, and you also have a role in the room. Your role, safely transfer this patient from the stretcher that you brought this patient from the pre-op transfer to the operating table. Sorry. Okay, so that's another rule. And don't make sure that this patient doesn't fall. Make sure you have somebody that is guarding the bed while you are safely transferring this patient from the stretcher to the OR table. And when the patient is in the OR table, put what do we call it again? That we use to strap them, a safety strap. We call it safety strap. Safety strap is just to strap the patient from falling off the bed. Patients in America, they take restraint very serious. Restraint is like tying a patient. Once you bring out that safety strap, and once you bring out the arm one to strap their arm to make sure that during anesthesia, as they are moving, their arm doesn't fall off the arm tables, at that point, they're seeing it that you are trying to restrain them, and it's a big crime here in America. So you have, at that point, don't even wait for patient to ask you, are you restraining me or anything? One was about asking me. Immediately I said, hey, Mr. A, I'm not trying to restrain you for any reason. If you think that's what I'm doing, your safety is very important to me. During anesthesia, you might be struggling and all that. We don't want you to, have fracture because you are struggling to move your arm. This is the reason why I'm using this to safeguard you. And the patient will be like, oh, okay, I was about asking, oh, I was wondering if you were trying to restrain me. I'm like, no. Another key role is to make sure that you assist the anesthesiologist, the CRNA. You have to assist them to induce the patient to sleep. Yes, because you'll be by your patient's bedside as they are going to sleep, still reassuring them until they receive that propofol that will make them to just sleep. Then when they sleep, that is at that point you start the main positioning. Remove the dresses, the gown that they are wearing. Then if there are positioners you need to add into this thing to support the positioning of the patient, that is the time you bring it in. And also you start prepping, clean with solutions. Of course, you've asked this patient, oh, do you have allergy? And if it's the procedure that requires that this patient is allergic to maybe chlorhexidine, you already know that ChloraPrep is something we use in prep in here. It contains chlorhexidine. You cannot use it at that point. You have to look for an alternative, maybe povidone iodine. You use it to prep the patient. And when you are done prepping, at that point, you stay back for the surgical team to the surgeon, the residents, the scrub tech, the SAs. This is the time they come in to prep the patient, like draping, so that the surgery will start. If it's a surgery that warrants or needs a Foley, before prepping the patient, that is when immediately the patient goes to sleep, that is when you put the Foley. You as the nurse can do it, the SA can do it, the residents can do it, the surgical assistant, the surgical technologist, right? They cannot put Foleys for patients. It's only the surgical assistant, the resident doctors, the main surgeon, the OR nurse. You can now put the Foley, but always ask before you put a Foley in, okay? So now you go back, the surgery has started. Okay, when you're done draping the patient, even before we do knife on skin, we still have to do a timeout. Everybody wants to make sure we have the correct patient and we are doing the correct procedure again. You do a timeout and then the surgeon starts the surgery. At this point, you go back and start documenting everything that you have done, right? From pre-op, when you came into the room, all the things you did for the patient, positioning, and all that. This is when you start documenting. Even as you are documenting, your ears has to be wide open. As you are documenting, your team could need anything. Hey, I need this. And because maybe you are not paying attention, they have to scream it. You don't want anybody to scream in the room for you. Hey, can you get this? No, you don't even want them to say it the second time. Your ear should be open to receive information. So if they need anything, leave everything you're doing. Go ahead and get it for them. Come back open under sterile conditions and surgery continues. At the end of the surgery, the surgeon must do a stop out. Confirm the surgery that you have done. Was there any specimen from this surgery that you have done? Okay, let's go over the specimen. I've done a surgery that I had more than 20 specimens, like 15 up to 10 frozen sections. We were going and going and going, sending and sending and sending. So if I'm doing that kind of surgery and I know that there are so many specimens that are gonna be involved, trust me, if you come into my room at that point to give me a break, maybe it's time for lunch, I will not leave my room. This is me personally. I want to make sure that I take care of all my specimens. The specimen, you can lose your job if you miss any patient specimen here in America. You can lose your job. You can be sued for that. Patients can sue you, but because what it means is, oh, that patient has to come back again for them to get that same specimen. You can't subject a patient to that kind of what word will I use? That pain, because it's pain coming back again. So I don't want to leave my specimen under the care of anybody. I take them out by myself. So even if it means eating after my case, I can wait. I'm that particular. Okay, so the doctor confirms that, oh, there is specimen. Okay, go over all your specimen. If there is anyone that was mislabeled, at that time, we have to correct it. But it's very important that when specimens are coming out, be recording. Oh, even if the surgical tech that will pass the specimen to you, because the surgeon brings it out and gives it to the surgical tech, who we call nurses, scrub nurses. In my country, we call them scrub nurses. These are also registered nurses in Nigeria, for instance. But here we call them scrub tech because they are not registered nurses. Some of them are nurses, okay, some of them are not. Even if they are the ones that will tell me the name of that specimen, I will still go back to the doctor. Hey, Dr. A, I have this specimen. Do you mind confirming the name of the specimen for me again? And he will tell you. You write it on a paper, go to the computer, put it in the computer, print out a label, put it on the cup, the specimen cup, come straight to the scrub tech. Can you give me the specimen? You read out that specimen again. Show her the specimen, not just read it. Let her see the labeling. Then she will pass that specimen. There is no way you will do this and you will have a mislabeling of specimen. But when it becomes a problem is when you have so many specimens at the same time and you are not guarded, you will mislabel the specimen. When you send it to the lab, they won't get the right result. So this is basically how the operating room runs. Then when the patient when they are done with the surgery, they wake the patient up. You scan the patient. I didn't mention count, but we all know that you have to count. Counting is very important. You count before you start procedure, you count. Once they start closing, you count at the end of the surgery. If there is any missing count, you must stop the surgeon. They will search the room. They will bring an X-ray machine into the room. If after searching, we scan, there's something we call a wanding machine is in the room, just a little box, cover the scanner with a sterile bag, scan it around the patient. If it beeps, that means there is a retained swab in the patient's belly. If there is, you have to open up and bring it out. Okay, if after wanding and we didn't also find that missing item, we have to invite radiography team. Let them bring in their X-ray machine into the room and do an X-ray right inside the OR. And when they do, they will tell us if there is anything that they saw. If they see something that the scan didn't see, we go ahead and open up. And one good thing about America, they will still tell the patient, so you don't hide anything. You don't hide any information because you finish closing and then you found out that, oh, an item was missing. You go back and open up. They usually tell the patient, they need to know what happened during the surgery. Do you understand? You don't hide anything from your patient. So that's it. Then prepare your patient, dress the patient up, take the patient to the PACU. We call it PACU, post-anesthesia recovery units. We call it recovery room as well. Take the patient, give the reports to the nurse in the recovery room, tell the nurse everything we did. If there is a family member that is waiting for this patient, when they recover, oh, they want to see their family, this is the person to call. Call the person and they will come see the patient. If this patient is not going to PACU and this patient is going to ICU, for instance, which happens almost every time, before you leave the room, once they start closing, call the ICU team. Hey, I have this patient. We are closing now. Are you ready to get a report from me? Give the nurse report. For patient going to recovery room, you can give reports at the bedside. But if this patient is going to ICU, we give reports in the room. In case if this patient needs to be on a ventilator, they get respiratory specialists to come and set up their ventilator and wait for the patient's arrival, into the ICU. So this is basically what we do. And when you have transferred the patient, you come back to your room, you start cleaning up your room. All right, clean up and start setting up for another case. You're not the one to clean the floor. We have people that do that. And okay, clean up the room, I mean, is finish up your documentation. Those cleaning the room are cleaning the room. They're setting up your bed. Sometimes I do that because I don't want to be late. I don't want to delay my surgeon. Most surgeons, when they are late on their surgery, maybe the first case was scheduled for 7:30 a.m. The next case is scheduled for maybe 10:30 a.m. And now we have gone past 10:30 a.m. because we are waiting for cleaner. The truth is sometimes I get the damn bucket and I start cleaning because I want to have a good day. If your surgeon is okay and they have a good day, everybody is going to be fine in that room. When your surgeon becomes tense, you don't want to get to that point. So I try my best. I know people will say, oh, why will I clean that? I do that sometimes. Not that I do it every time. Do you I do it just to make sure that I'm not late in bringing my patient outside, making your surgeon angry because you are late in the room. What about this patient that has been starving since maybe midnight and have not eaten anything? Do you understand? You also consider this patient. Try and be fast. Bring the patient up, let them do this surgery, recover, and go eat something. So these are little things you do, and your team will be happy. And at the end of the day, oh, thanks for a great day. Oh, thank you. It was a great day. Everybody will be so happy in the room. And, you know, that's just basically the activity in the OR. Thank you. I hope I answered your question,
Wow,
Mr.
wow. I feel like clapping for you. You deserve a standing ovation for all this, man. Thank you so much. You really went so deep into it, just the same way I wanted, because I've been hoping to host an operating room nurse who will give us a, very insight to how a day-to-day activity, happens in the OR. And you did justice to that. And whether you are in the ER, in the OR, whether you are in the med-surg unit, anywhere you find yourself in the United States, there's one key thing that's going to help you from what she said: paying attention to details. If you always pay attention to details, you will never go wrong. Yeah, one of the award, she's gotten many numerous awards, but one of the awards that she got that really, really touched me was the one that the surgeon was already about to put in a Foley catheter on a patient that is allergic to latex. That catheter was made of latex. And she was in the room and she was able to catch it. And guess what? This is the way you announce yourself in this country. You cannot announce yourself by speaking English. Come on, you can't even speak more than them. So the only way you can announce yourself when you come over here is by paying attention to details. You understand? That's the only way. You can stop the line and say, hey, I feel like this is not right. Let us check this thing that we're trying to do. And when they check it and find out that you're actually right, even if you don't speak like they speak, they will still respect you. They will still respect you anywhere, anytime they see you. They know you're a valuable asset because they know you are contributing. Know how much the hospital would have lost if they had operated on the wrong leg for the one that she described. And then if they had put in that Foley and the patient ended up suing the hospital, they would lose a lot of money. So by the time you do this more often and and people begin to know you as one of the nurses in the hospital that pay attention to details, you are going to be in the good book of both the leadership of the hospital. You're going to be in the good book of your teammates. Everybody want to work with you. Even the doctors in the hospital, they want to work with you. And even in the med-surg department, even